Good morning and good afternoon, wherever you are. My name is Jepchirchir Kiplagat, a lecturer at Moi University School of Public Health, and I also work at the AMPATH program, one of the HIV care facility in Western Kenya. Today, I would like us to discuss models of care for older people living with HIV, how we are implementing this in practice, and giving some of the experiences from our setup. As we delve in, and I want to look at this, projected age for people living with HIV and on treatment in Eastern and Southern Africa, we're seeing a demographic shift where in the next 25 years, majority of people who are living with HIV will be people age 50 years and above. And this is something that is attributed and gladly to the ART success. But beyond that, we're seeing also a number of new infections among older people living with HIV. And as this demographic continues to shift and has been shifting for a number of years now, we want to think about, models of care and why they matter, particularly for older people living with HIV. And as we think through this, getting a feel of what is currently happening in siloed healthcare delivery, where we have traditional HIV clinics focusing more on single disease, focusing more on ART, opportunistic infection, when in essence, realities of older people living with HIV has changed. They're living with multimorbidity, issues with polypharmacy, geriatric syndromes. But beyond that also is other complex needs that are social in nature, that include stigma, poverty, caregiving roles. That's where their children, they've lost their children, and they're taking care of their grandchildren. And to then, ensure that we are living to these realities, we need to think about models that, offer a framework to deliver not just an integrated care, but also one that is patient-centered, that is holistic, and also sustainable. And we've seen a lot of, evolvement within the African setup, and this has occurred in various areas, including integration of chronic care clinics. We see community-based differentiated service delivery. We see peer navigator or lay healthcare worker support. We see geriatric assessment integrated into HIV care services. These are models that are coming up, or models that are evolving within our setup that we feel would be leveraged to really meet the needs of these older people living with HIV. I'll delve a little more into details in the majority of this to give us a feel of what is currently going on within our setup. And a scoping review that was done sometime in 2018 by Njuguna and team really looked at, within the African setup, what are some of the models that exist that integrating HIV and NCDs. And there were several cases. They identified 5 cases for that matter. One is where community-based integrated HIV and NCD screening and referral is being offered. So that's where within the community, there's screening for HIV, hypertension, diabetes, cervical cancer, mental health, and then if anyone screens positive, then they will be referred into healthcare system for treatment and care. And then we have the second case where you offering screening for non-communicable diseases within, and non-communicable disease risk factors within, the HIV clinics. And this is where you're screening for hypertension, screening for diabetes, screening for mental health as patients come to seek care within their CCC clinic, comprehensive care clinics for their HIV care. The third case that we see for integration is where tools for HIV, which have been well established, have been adapted to also collect data for NCD. And these are tools that are now being used within the NCD clinics that allows for streamlined care and to also streamline data that allows for, an informed decision in, the data that is being collected. Beside that is a fourth case where we're seeing a core integration, where we're seeing HIV being now integrated in an all-inclusive chronic care clinics. So there are chronic care clinics that offer hypertension, diabetes, mental health, and HIV is being introduced into these clinics, whether it's screening or also management, including dispensing of ART and the overall, long-term care delivery for them. And then the fifth case is population health model, where you're really looking at an individual from not just the clinical care and medicine dispensation, but you're also looking at other social determinants of health that includes the housing, access to food, poverty-related issues out there, and looking at, an overall individual from both physical and also psychosocial care and support. Besides that, I want to go into detail to these integrated HIV care models that we are implementing in our various setups. There are a lot of published data on HIV and CD integration. But I would give an example of what we're doing within the AMPATH, and I know this is also happening in Ghana, Nigeria, Uganda, Tanzania, Kenya, where we're having HIV clinics, as a platform where as people living with HIV come for their normal clinic visits, they're being assessed or they're being screened and managed for other chronic diseases. This has been such a great and been beneficial, not just to patients, but also to the care and facilities themselves. In terms of reduced clinic visits, we have costs of care just for the patient, but also for the care delivery system as well. Improve monitoring, because if that data is collected, in a systematic way, allows for monitoring of controls, whether it's hypertension, diabetes, and also viral load suppression. And allows for task sharing with nurses, with clinical officers. What would otherwise have been done by one clinician can be shared between the nurse, the clinician, the nutritionist, the social worker, in terms of screening and also supporting these older people. While this is beneficial, we see a lot of challenges as well, issues to do with supply chain, medication for hypertension, and other chronic diseases can be a deterrent here, and that lack of consistent access to NCD medication can really affect, continuum of care for NCD. Workforce training, HRH, that's a health, the human resources for health training to ensure that they're able to support older people living with HIV and offer, a holistic care delivery for that. Data integration also, where health systems are also, or rather EMRs are also integrated, not just to collect data for HIV, but to collect data for all other conditions outside of HIV, and monitor and track that is also a challenge, because without guidelines also really that it becomes a big issue. We have community-based models. These are also published work in Uganda. We've seen some in Kenya. Again, in Southern Africa, we see these differentiated service delivery models where we have ART groups, people just form groups. And within those groups, it allows support for a member of the group to come and pick medication for, the rest of the membership of the group, multi-month dispensation of ART. This is really something that is very helpful for older people who have mobility issues, even when they actually have achieved viral load suppression or are stable in nature. But unfortunately, because they have to come on a regular basis to pick medication, then that causes, issues, that travel. And honestly, these DSD models have been really a big step in support of older people living with HIV. We have peers who support the navigation of the system, whether within the healthcare facility, to educating their fellow older people on issues to do with medication adherence, issues to do with comorbidities, and other, related conditions that they could be suffering from. And honestly, just offering the social support in essence. And this has been shown to increase their adherence, not just to HIV clinic visits, to HIV medication, but clinic visits as well, and also medication to other to chronic diseases. And then it has reduced congestion in clinics, but has offered also peer empowerment. The third model is where we are introducing comprehensive geriatric assessment within the HIV clinics to assess mobility, ensuring that we are optimizing, functional status and maintaining safe mobility for older people living with HIV. We are assessing mental health related issues. We are also looking at polypharmacy and ensuring that you are tailoring medication to meet the goals and preferences of the people, of these older people, but also avoiding high-risk medication, and also trying to navigate this complex environment where there's social-related issues that really come into play when you're looking at the healthcare and the outcomes of this individual. And generally, what matters to these people? What are they planning? The advanced care planning and all. In AMPATH, we are currently prioritizing, assessment of comprehensive geriatric care for older people living with HIV using this WHO equipped tool, where we are assessing cognitive decline, limited mobility, malnutrition-related issues, visual impairment, hearing loss, polypharmacy, depression and anxiety, and also comorbidity. And we've seen this pilot show or rather identify geriatric condition, but besides identifying the geriatric condition, we are testing the feasibility, and we're seeing it's feasible in high volume settings, but you have to have a trained provider. I know this has happened in Newlands Clinic in Zimbabwe, where they're seeing also older people living with HIV and conducting comprehensive geriatric assessment. So that feasibility testing to assess, implementation is still ongoing, and we hope this is something that also will be taken up at the national level by countries. And then we've had lessons, of course, in the implementation of these models that I've talked about. And some of the facilitators to implementing these models include the task shifting or task sharing, the great infrastructure that HIV was set to offer can really be leveraged to offer NCD care and other service delivery, the peer support system where peer support models have really been built and people are coming together to support each other. Donor alignment, to people's needs as well, and the demand of the patient to want, patient-centered care. But of course, this is without no barriers. We've seen a lot of challenges, including silo in funding, NCD care service delivery still it receives limited funding. Geriatric expertise is limited within our environment. Stigma, not just for HIV, but also for AIDS, as you know, ageism, you'd say, lack of metrics for monitoring, other chronic diseases within an individual living with HIV, and also the guidelines that are not in existence right now for integration. I believe most countries, including Kenya right now, is also developing guidelines for integration. I would say, as a big lesson, no one size fits all. So you want to adapt your models to fit the local health systems, the resources that you have. But beyond that, also what works in that environment. For future directions, we're seeing scale up of integrated HIV and CD care and geriatric care, harnessing digital health tools that would allow good monitoring, strengthening community engagement to address stigma and social determinants, but also the need for guidelines for this integration or integrated services. In conclusion, older people living with HIV require tailored integrated care models, and existing pilots have shown promise, but we still need to scale them up and also ensure that they're sustainable. And within our setup, the experiences that we're sharing would provide valuable insights for global aging and HIV discourse as we continue discussing this. I believe healthy aging with HIV is possible if care models evolve with the needs of our patients. These are my references, and thank you so much. Happy to answer any question.